team of the African Organization in Research and Training in Cancer, known as IOTIC. Dr. Hammad is visiting professor at the University of Nairobi, Kenya. She is the co-chair of the Network for Advancing Black Learners in Ontario. She is the former director of Global Health, Faculty of Health Science at Queen's University. She is an executive member of the Global Oncology Program at Queen's University. Dr. Hammad has a keen interest in medical education, in particular health professional education in low and middle income countries. She has a master's degree in medical education in health profession from Johns Hopkins University. She teaches regularly at the Clinical Oncology Training Program in Khartoum, Sudan, and as a visiting professor at the Medical Oncology Fellowship Training Program, University of Nairobi, Kenya. Her area of expertise include training program development and evaluation, curriculum development, mentoring and innovation in education. Her work on education has been presented at international conference and published in peer-reviewed journals. She's a recipient of several grants in education, including the Royal College of Physicians and Surgeons of Canada International Development Aid and Collaboration Grant in 2022 for faculty development among African oncologists. Her other area of interest include value in cancer care. Together with colleagues in African, she led the first Choosing Wisely Africa that was recently published in the Journal of Global Oncology. Their mentor, Dr. Nazik will be discussing with us the collective collaboration to empower girls in medical school. So at this point, I would like to welcome you, our dear mentor Nazik. You are welcome to speak to the attendees. Thank you.
Thank you so much for inviting me. It's indeed a pleasure. I'm very proud of you guys creating this association. I have a lot of connection with South Sudan. My sister is married to someone from South Sudan, and I'm from the South White Nile area. So it's just very close to South Sudan, and I have a lot of friends from there, and I had a lot of friends at the University of Juba and elsewhere, so it's indeed a pleasure to be here. I will share my screen, and please let me know if I'm going over time, because I'm just a little bit jet lagged. I just arrived yesterday from, can you, it says disabled share screen. Can you enable sharing screen? Because I have slides.
Sure, do that.
Okay, I'll try again. No, it's still not. It still shows disabled. Can you make me a host for a little bit? Okay, let's see. Yes, I believe this is the right. Let me just see if it's the right presentation. Yes, can you see my presentation?
Very clear.
Can you? Okay, let me just share. Go to slideshow, and so they say thank you very much for allowing me to come and join you. And so I really changed the title of the topic because I wanted to talk about investing in the future and empowering female medical students rather than saying girls. And so we know that African women have always been healers. So I grew up, my grandmothers know how to use certain medicine, how to take care of the sick, how to use natural herbs, and some of them were very, very skilled. However, in modern medicine as we know it, it took women a long time to be accepted into medical school. So if we go to the, what is the history of medical schools in Africa, looking from 1986 to 1980, these are the first 6 medical schools. So in the 1918, you have the one in Senegal, University of Cape Town, 1919. We have a career in Uganda, was 1923, immediately followed by Faculty of Medicine, University of Khartoum. And I graduated from the Faculty of University of Khartoum, and also a lot of students from South Sudan also graduated from the Faculty of University of Khartoum. And so why is it, women got into medical school late? Most of it is because of colonial legacy. These medical schools were started either by the British or the French. And these colonial men and their way of thinking medicine, even in the US or in Europe, in France and in the UK, was for men. And the idea is that they were, they became rich, they come to African countries, and then women can stay at home because they have maids. But the truth is, African women rarely ever stayed at home, okay? And now we see that the percentage of women is increasing in medical school. So this is the University of Khartoum as an example. In 1928, there were no women. By 1985, there were only 25% of women. Now, by 2009, the number of females have increased to close to 70%. So now they are in the majority. And as you see, this is what's happening. The percentage of female who graduated, it went up to 80% by 2008. So feminization of medicine is an increased presence of women in medicine is universal. It happened throughout the world, everywhere in Canada, in Europe, that women are getting into medicine more than men. But it's what's happening, and actually characteristically in Africa, it's happening at a more accelerated rate. We're seeing African women getting into medicine in very, very high numbers. And we have data for that from the awarded African Organization research work that we did. I can present it in the future. This was paralleled by also traditionally in Africa, girls had less access to school. So my father was we grew up in the village in the southern White Nile area. And he was we managed to go to school, but my aunts did not go to school. So by 2000, like here in 2000 compared to 2002, the primary school completion was 49% for boys and 61% for boys by 2020. But for girls, it went up to 66%. So girls are achieving at a much higher rate than boys. So for example, completion in upper secondary school, here was 17%, it went up to 26% for girls. So girls are doing better, but we know there are still girls who are in the village, who are in urban poor areas, who cannot find and are not sent to school. What's happening to girls who go to school, to women who go to school? Their increasing number has not been associated with the decrease in the barriers to professional and career success. And there are several factors that start even prior to medical school, continue through medical school and residency and during professional life that make women less likely to succeed in medicine. And these could go from admission. Sometimes there are barriers to admission to the medical school, educational experience as a medical student, and also experience as a resident or registrar in postgraduate engineering, and then access to career development and leadership position and to mentoring. So, because most of it is a gender bias. So although the health sector workforce is one of the most female in composition, women are less likely to be found in senior professional managerial and policymaking roles. And so some of it's related to society, attitude in the society. And society include especially men in power. because there's a double standard, okay? Girls' education in Africa is not a right in many countries, but however, African women, they work in the fields, in the farms, they tend animals, they fetch water and food and wood, they sell in the markets and by the roadside, they work in construction, they work as maids, etc. But the men in power are not usually upset by this. It doesn't bother them. They're not doing a lot to improve the lives of working African women. But they get upset when women work hard in better paying professional jobs, such as law and medicine, because it seems like now there's sort of a competition. And also there's a colonial legacy of where you want your wife to stay at home and take care of the kids, which is not really what African women traditionally did. So here they are working harder than ever in the markets and in the farm. So why this negative attitude, cultural attitude and gender bias against women? Sometimes when young women enter the medical school, they're often subjected to negative cultural attitude, especially in the learning environment. So one of the attitude is that women don't work hard, but we know that nobody works harder than African women. Women are less competent. Women cannot make decisions. Women cannot lead. Women will not work in rural areas. Women will quit medicine and go stay in there as soon as they get married. Women are not teachers, good teachers. Women are not good researchers. So a lot of mythology that does not really bear any truth. And the negative attitude towards women in the classroom and by the bedside during clinical teaching. So these hostilities, mistreatments, and microaggression are found in the learning environment. And who are the perpetrator? Who does that? Sometimes faculty, some male students, not all male students, some male students are excellent colleagues, some residents in the postgraduate area, even sometimes from nurses and other staff. They do not respect women doctors as much as they respect men doctors. And so what is microaggression? Microaggression is a term used for commonplace daily verbal or behavioral environmental slights, whether intentional or unintentional, that communicate hostile, derogatory, or negative attitudes to stigmatize or culturally marginalized group. So example of microaggression for women in medical school is public humiliation, sexist remarks, sexual harassment, comments on their dress or body shape, giving lower grades or evaluation, denying training opportunity, lack of accountability from the medical schools, and lack of pathways for reporting microaggression and mistreatment. And there's something called the hidden curriculum. So we have the formal curriculum. It consists of what we say we teach. Okay, so these are the education, classrooms, and then there's the informal curriculum, which is the interaction you have with in the clinical learning environment between the teachers, the students, and within the milieu and during the course of learning. The hidden curriculum is ways so that institutional policies and practice which serve to enforce certain actions and constrain others. So putting barriers in front of women or saying that they will not work hard and not giving them opportunity. So how do female medical students, trainees respond? Because we say that women are not, they still want to go to medical school and they're getting there. So sometimes they do not report. Most of the time they do not report because reporting can lead to retaliation. If you report, if you go and complain, they will say that you are hostile, you are bitchy, or Galilat Adab, as we say in Sudan. Unofficial peer, they also depend on unofficial peer support and strength in number. They seek protection and mentorship from female faculty, but that's not enough. More need to be done. So why more need to be done and to support women in medicine? Because women will lose a lot of energy trying to deal with the barriers. And that means we lose their talent and we lose the resources of them. So what are we losing when we do not optimize women's role in medicine? The consequences. First, there is loss of huge talent and contribution because all of these women have a lot to offer. Women are less likely to immigrate, to participate in the brain drain. They are more likely to work in poor urban areas. For example, here in Khartoum, if you go to the peripheral health centers, you find more women there. Women doctors are likely to apply evidence-based care, implement guidelines, and patient-centered care. So do we have evidence of that? So we know a lot of the time people judge women's contribution by the fact that, okay, they don't go to rural areas, or they say they don't work long hours. So, but then people said, this is describing their work. What we need to know is patient outcome. If I treat this patient, will I do a better job or not? So we have this, I don't know, there are some people waiting in the waiting room. I hope I got them in. So patient outcome. So let's take two examples, one from Canada, one from the US. So we know from the literature is that women are more likely to adhere to clinical guidelines. They provide more preventive care. They use more patient-centered communication. They perform as well or better on standardized examinations, and they provide more psychosocial communication and support to than their male peers. Okay. Okay, I will admit everyone if I see them. Yeah, I think I admitted some people. Okay, so when let's say this article just came come out in 2017, and this is on internal medicine. So they found that in the US, all like millions of patients, this is Medicare patients, elderly hospitalized patients treated by female internists have lower mortality and readmissions compared with those cared for by male internists. So now we are starting to look at population level. And so anyone who will say that women are not doing a good job, they will know that if you're taken care of by a woman, the likelihood you get a better outcome. That doesn't mean male doctors are not doing, but in comparison, women are doing great jobs, okay? And then they looked at comparison of post-operative complications like surgery. Women find it very hard to go to surgery, correct? The surgical department do not accept female residents easily. But when women manage to get into surgery, their post-operative outcomes are less. So patients treated by female surgeons have better post-operative outcomes. They have less complications and less mortality within 30 days from the surgery. Okay. And then this last article I'm going to talk about came out in 2022, and these they looked at thousands of patients in Ontario. And so they said, okay, if women are doing better in complications after surgery, what's happening if your surgeon is a man or your surgeon is a woman? And they found that if you are a woman treated by a male surgeon, you tend to have worse outcome. Okay, but if you are a female surgeon treating a male patient, but you will have the same outcome. So that means there are ways of women bring a lot to medicine: attention to details, attention to patient complaints, and attention to prevention of infection. And so this was death, readmission, or complications. So in Africa, women, if we go to the history of female teachers and midwives, they have had excellent track record of rural service. However, sometimes female physicians may not go to rural area, not because they don't want to, but because the increase in female medical doctors occurred during a time when African governments have stopped investing in adequate accommodation and infrastructure for staff in rural hospitals. So in the old days, if you have a rural hospital, there will be a good, decent housing and decent infrastructure for doctors and for teachers to go there. But now it's non-existent, so it's even difficult for male doctors to go. So we need to change the health system, not to decrease the number of girls in medical school. So how do we empower women? We address power dynamics, gender bias, and the hidden curriculum. We become accountable to women. We create mentorship opportunities for female trainees. We ensure that female students are represented in medical student associations. So I hope you have a good representation of women in your association, and they should have access to leadership positions and in these associations, because that's why it starts in medical school. So medical students need to lead the change, because these These women are your colleagues, that are your daughters, your sisters, and your mothers. And when they go out, they will treat your family. And so they do a good job in treating patients. So we empower, we should hire and empower female faculty. We should increase access to research grants and research opportunity. And then at the health system level, we should how the work environment. Even in rural areas, the government should invest in better housing and better accommodation. And how to address the hidden curriculum that says women are useless and all of that. Sometimes even your own faculty, your own teachers may be saying that. So we need to conduct research into the magnitude of gender bias and microaggression. We need to raise awareness about the problem. We need to empower national and regional female physician association for activism so they can talk to power and create policy changes. And we need to create mechanisms for reporting microaggression and mistreatment and holding the perpetrators accountable. And so opportunities and uptake of mentorship by female students and young doctors. Sometimes male students are better than getting opportunities for mentorship. Why? Because there are more male senior faculty are still male. There is less time for women to pursue because they have to juggle work and life and family life. And also, there is lower status for women in the global health ecosystem and cultural factors. So male physicians sometimes are more aggressive in pursuing mentorship. So that's why in your association, you should encourage the females to go out and look for mentors. Okay, and we have studied this in Awotic, and this was presented as an ASCO challenges faced by female oncologists in sub-Saharan Africa, which are female doctors, and this pressure to maintain work-life balance, lack of female support, microaggression, lack of mentors delivered by women led by men, so that at the level of leadership, they're not given opportunities, lack of support, lack of access to staff infrastructure and leadership, being perceived as less competent, dysfunctional pipeline, and the glass ceiling. The glass ceiling means they can't get beyond a certain point. Okay, so, and this is a good example from the Ethiopian Medical Women Association, where they said, we want to create a culture in which Ethiopian women in medicine can enjoy equal rights, where they can safely gain access to leadership and management training that enables them to advance professionally and participate more equally in decision-making by giving Ethiopian women in medicine greater voice and platform. They can improve the care in that country. So I hope from the school from your medical association, maybe a medical association for South Sudan, female physician can be formed. So in summary, and this is my last thought, female medical students are a precious and valuable national resource. Women in medicine must be empowered through addressing cultural barriers, gender discrimination in educational institutions and in workplace culture. Solution must involve all stakeholders, including male physicians, because male physicians have a big role to play. You can get, you will get better colleagues, better men, because women do a lot of mentorship. So like Akwi and myself. So health system change is also needed to tap into the huge talents and potential contribution of women. And this is the East Africa region from Eritrea, Ethiopia, Sudan, South Sudan. All of us in Egypt, all of us should come together to share knowledge and best practices. Thank you so much. I'll finish here and stop share.
Thank you so much, dear mentor, for that presentation. You have spoken a lot, and there is really a lot in your presentation. Thank you so much for that. I've learned quite a lot of things from this presentation. You talked a lot about some of the problems that women are facing in medicine, and this includes some of the traditional belief that we have as African, not prioritizing girls' education, the microaggression and mistreatment that women face. You also did talk about the consequence of not empowering women in medicine. You mentioned quite a lot of points. You brought in researches that were done in the previous years, that highlights some of the important points like women, person treated by women have better outcomes than those treated by men. This is really something very tremendous to hear always. That means women are really playing very, very great role in medicine. So there's really a lot that we have to do and have our women, girls empowered. So I have a question to you, but before that, I'm very sure our attendees, the medical students here who are here with us, they are listening to you, by the way, and I'm very sure they might have questions. So at this point, I would like to give time to them. Then after that, I will also throw my question to you. So if anyone is having a question at this point. Okay, as we wait for the student to give their question, I would like to also start by giving my own so that you will respond. Then after that, if any other student is having another question, then he or she will be welcomed. So we talked about the traditional aspect of in Africa, especially women are not taken seriously, like in medicine, because of the attitude that we have in society. So yes, there is a very common belief, something that also happened in medicine that I have observed in the life of ladies and the women who are in medicine. So I would like us to like to understand more from you, and I would like to hear what you say about it. So for like some girls, like they did not join like medical school, for instance, medicine, because it takes many years to finish the course. And others, even after joining, they quit. So how would you advise girls in medical school to commit to their goals, regardless of their age, given the fact that reproduction in women stop at certain stage of their life?
I think it's not, it can be done that women can continue through medical school. Sometimes it's a lack of support that makes it, easier, not easier, but makes it an incentive to quit, okay? Because as I said, if you come, you're told you're not good, you are getting more, there's no support. So hospitals should have nurseries to help them take care of the kids, because having children should not be a barrier, because African women always have children. They still work in the they still work in the field, they still work in the farm. So why is it just because everyone is expecting, they don't like the expectations or the type of work is done is focusing on speed, like let's see has this, but they don't realize that like women sometimes even if they do half a day of work, it could be quality work and it's good work. So during reproductive years, there should be some policies that will allow women to work reduced hours or support them with more staff, because I can tell you like if there is some nursing support, most likely be given to the doctors rather than to the male doctors rather than to the women doctors. So there has to be deliberate policies put into place, because these women, the reproductive life is what, 10 years and then they can also come back, but women can work for 40 years, and that loss is huge. No, if we just allow them to drop out of medical school and stop. And also, like for example, if you look at, I remember when, maybe your generation is better than my generation, but when I was in medical school, the Medical School Association would refuse, they have to have only two, the student association, only two girls. They have to be the assistant secretary. They can never be a real secretary, okay? So not, so it's not having access to express their talents. All of this is demoralizing. It can dampen their ambition, although they're trying their best. But we need to talk about these things now to support them. Then those who are finding it hard to continue, then will continue, and so we do not lose their talents. And I'm so proud of you guys for bringing this topic, because I can tell you this is the first time I teach a lot in the University of Khartoum, but nobody has asked me to talk about this topic. They bring it, but you guys are a pioneer, and so I'm very proud of you. And I think this is what's going to make the changes: raising awareness and starting the process of people understanding why, doing research on why, and enacting into policies. And then we will get there where there is equal rights for men and women, and we'll get Africa will get the best of talents of both.
Wow, very well answered. Thank you. You have really given a very good point, and we have a lot as a medical student, like you said, in our association. We have to encourage our females to even look for mentorship program. And I believe by so doing will really help our girls and the sisters a lot in the medical career, because we have to go together with them, and they actually play a lot of importance, like in the medical field. So your point is really very great, Demet. I really appreciate your presentation. Thank you so much. So yes, student, this question. So